right.
Great.
So,
So let me just say welcome on behalf of the Down Syndrome Connection of the Bay Area. And if you guys would do us a favor in the chat, in the, not in the chat, in the Q&A, can you jot down the age of the participant that you are representing that has a dual diagnosis, whether it's your parent or a caregiver. And we would also like if you could put in what kind of behaviors that you feel are kind of impeding your child, where it's kind of impeding their daily living and learning. So that would give us a good way to kind of hone in on really helping you guys.
Yeah, that'd be great. Specific questions related to sensory diet as they come along, just put them in the chat, as Teresa said. And although we can't see you, I really do want to be able to communicate back and forth with each of you about your child's specific sensory needs. So what we're going to do is I'm going to go over broadly just what Down syndrome and ASD combined looks like, general characteristics, diagnosis, and then we'll talk briefly about what a sensory diet is. And then we're going to take a small break for you all to go over the sensory checklist that I provided. It's like a sensory profile. If you've ever worked with an occupational therapist, they will give you a document like this where you go through a series of questions for each sensory system to identify your child's profile. So we'll break to do that. Then we'll come back and go over the different profiles and sensory tools that would be appropriate for that profile. So that's the plan. All right, so we have a little technical difficulty. Teresa's managing the slides. My computer is, for some reason, not happy with me today, so I'm on my iPad. So let's move to the first slide, Teresa, of Down syndrome and ASD. I'll look at what we know. So until recently, it was commonly believed that these two conditions, Down syndrome and autism spectrum disorder, could not exist together. Parents were often told that their child with Down syndrome had a severe cognitive impairment, and that was an explanation of the symptoms that they were seeing that appeared to many parents to be on the spectrum. But today the medical community is starting to recognize that people with Down syndrome can also have co-occurring conditions like ASD or OCD. Kennedy Krieger Institute in Baltimore has done a lot of research on this combined diagnostic category. There's a physician there who has taken a large group of children with Down syndrome and ASD and has watched them over time and collected data and compared the characteristics of children in the DS-ASD group to children just with Down syndrome. And so a lot of what's pushed this diagnostic category forward is the work that's come out of Kennedy Krieger. And so they estimate there that the prevalence is somewhere between 1 and 10% of children with Down syndrome will also have ASD, although it's difficult to diagnose, as I'm sure many of you know, because there's such disagreement among professionals about what diagnostic criteria you use. So if you could move on to the next slide, Teresa. What we do know is that there's two types of presentations. So the first presentation, we see symptoms at atypical behavior starting early. You might see repetitive motor behaviors, such as fingers in mouth, hand flapping or stimming, fascination with lights and ceiling fans. A big one that we treat a lot in OT is food refusal, extreme feeding, sensory-based feeding issues. Sometimes there's a motor component as well. Yes, fingers in mouth too, that's right. Receptive language problems, which you'll see as poor gestural use, so not using gestures early on. Even appearing, some families might think their child has a hearing impairment because they're not attuning to auditory input. So their hearing is intact, but they're not turning and orienting to sound or to someone's voice. When language does come in, it could be scripted or delayed. And we know that actually there are medical conditions, even more medical conditions within the combined group that can coexist, such as seizures, a dysfunctional swallow, which can also contribute to the feeding issues. Nystagmus, which is when the eyes can't stabilize and you'll see them moving back and forth. Severe hypotonia, really low muscle tone, even more so than what we would see in the population of Down syndrome. And there's a delay in motor skills. So if presentation 2, if we can move on to the next slide, this is also what we see in ASD in general, where a child was developing along the typical developmental progression, and that developmental progression meaning typical for a child with Down syndrome. And then when they hit the ages of 3 to 7, there's regression. And that developmental regression includes a loss of skill, a loss of language, and it often is followed by a period of excessive irritability, anxiety, and onset of repetitive behaviors. So within the population, these are the 2 presentations that have been identified are pathways to that diagnosis. So if we move on to the next slide and talk about the path to diagnosis, and I know Kathleen, we're not going to have you here long, so I'd love for Kathleen and Teresa to share after I go through this slide. You know, getting a diagnosis is not an easy ordeal. How do we get there? You know, there are many professionals that will still tell families that their child with Down syndrome is just exhibiting lower functioning due to cognitive deficits. So there is disagreement, as I said, in the medical community about which evaluations to even use. Do you use the autism evaluations? What criteria? And there's lack of acceptance with professionals still that the 2 syndromes can coexist. So Kathleen, would you share for a minute about your experience? And then Teresa, you too, I feel like you forged the way since the diagnosis was a long time ago, but just share about this piece, like that path to diagnosis.
Yeah, sure. I'd be happy to. So my son, Sam, is 9 now. He was diagnosed with the dual diagnosis when he was 7. And to be honest, I did not think that he had it. I have an older son on the autism spectrum, and Sam did not exhibit any of the same behaviors as my older son. So I thought, to be honest, that they were a little crazy when they told me to have him assessed, but I did, and he ended up on the spectrum. And when they explained why, it did make sense. You know, my older son is your stereotypical difficulty with eye contact, hyper focused on certain things. You know, fabulous kid, does great, but he does have stereotypical autistic behaviors. Sam is actually, he's my one with Down syndrome, very friendly, very warm, great eye contact. The biggest thing with him is a severe speech delay. And that was actually what led to his diagnosis. There were a few other things too, but the speech is really what it was. And when they pointed it out to me during the assessment, they said the way that he uses language is much more like an autistic child than a child with Down syndrome, because he would only repeat, he would try to repeat anything you would say, but he didn't use spontaneous language hardly at all. Right. And he will repeat the last sounds of things. So like if you would say, how was your day? He would just go day instead of giving you any sort of, you know, contextually appropriate response. And there were some other pieces too of language that had been lost, but it wasn't as severe as you hear, like you hear about kids on the spectrum who lose all their language. That wasn't it for him, but there were little pieces that were missing. And then when he does use it, it's always when prompted, it's not spontaneous. So that was a big surprise to me. In retrospect, though, he does do a lot of autistic behaviors, you know, a lot of stimming, hand flapping and things. but some kids with Down syndrome who don't have autism do those things too. So
That's right.
that wasn't really a
Yeah.
defining characteristic. But now that I know he has it, I see how the autism sort of overtakes the Down syndrome, and the sensory issues really, you know, everything has to be just so. The cup
Yeah.
has to be placed here on the table. The texture of the food has to be this. And it really does kind of become all encompassing. So it's
Yeah.
hard for me.
Yeah. It is. Thank you for sharing that. And I think that that's the piece that will confuse parents, but also pediatricians, and that the children with Down syndrome are highly social, and children with that combined Down syndrome ASD, they show less impairment and social relatedness than a child on the spectrum. And so that's the piece that I think can be sort of a roadblock. Teresa, what was your experience?
Well, you probably saw me shaking my head a bunch, because very, very similar to Kathleen's. When we lived in California, in Livermore, we had him evaluated for autism. So this was 20 something years ago. The testing wasn't near as good as the second evaluation we got 6 years later. But at that time, same thing, very highly social, made good eye contact. They concluded that he did not fit on the spectrum, and the speech was largely due to a verbal apraxia. And he did have sensory integration problems. So fast forward to 6 years later, when he was 10, we revisited, and the evaluation was a full team. And at that time, I kind of knew, I could tell, you know, the stimming was really overtaking every aspect of his life. His speech was not coming along. And so at that second evaluation, he definitely hit the criteria. Again, not the spontaneous language, not there. His receptive language was really good though, actually. And the apraxia, that's kind of what made it confusing. So it's really hard to tease out these symptoms. And I will second the fact that the autism becomes the major diagnosis in, if you were to put it in the IEP, I would say autism and Down syndrome in that order, because that's the
right.
part that you need to treat.
Yeah, that's right. And that's the part that needs the most support and accommodations in schools. So thank you for sharing that. And this is where I wish we could have parents participate and share their stories. So feel free to add things or ask questions in the chat. We'll move on to the next slide. So behavioral findings of children with Down syndrome and ASD. So there may be a history of developmental regression, or loss of language skills, or poor development of communication skills. You might see self-injurious and disruptive behaviors like skin picking, biting, head banging, repetitive motor behaviors like grinding teeth and hand flapping, which, as Kathleen mentioned, is also something that we see just with children with Down syndrome. So there's an overlap there between the two diagnoses. Unusual vocalization, but here we go, the unusual sensory responsiveness, right? So when we talk about sensory responsiveness, a little foreshadowing as we move forward, we typically look at each sensory system. So are we talking about your tactile system, which is touch? Are we talking about sound? Auditory? Are we talking about movement, vestibular? Are we talking about proprioception, which is your joint position? So there's unusual sensory responsiveness. We could be over responsive or under responsive. Feeding issues, food refusal, strong preference for specific textures. And so just pausing here for a minute, feeding problems, you know, it's one bullet point, but it is a huge challenge for children with a dual diagnosis, because you have possibly oral motor challenges that's coming from low tone and poor, especially in your example, Teresa, with your son, apraxia. You know, it's difficult to coordinate the muscles of your mouth and your tongue to move food, create a bolus, get it get it exactly where it needs to be in your mouth before you swallow it. And so kids don't feel safe eating certain kinds of food. In addition, they just might not be able to process the sensation. And so there's a lot of refusal. And so you might have a child who has a very restricted diet where they're only eating one or two things. And feeding therapy is something that needs to be ongoing. And that's a whole area, another area that I feel like we could talk about as a separate, within the DS-ASD, but also within the DS population, because there's different approaches to feeding. But I'm digressing. We might also see increased anxiety, irritability, difficulty with transitions. And so if you go through this next part, this sort of outlines, well, what is the difference between a child with Down syndrome and ASD and a child with just ASD? And what we know, again, is that children with the combined diagnosis of DS-ASD will show less impairment in social relatedness. And, I'm thinking about Kathleen talking about Sam, and I remember his big smiles and wanting to be with people. But although there was the social relatedness piece, there's also that delay in communication. And I think that's a piece that's important to look at. Children with Down syndrome and ASD show more preoccupation with body movement and object use than children with ASD alone. And children with Down syndrome and ASD will score higher on the autism behavior checklist than children with just Down syndrome. So that there's some characteristics there that will help us kind of tease apart. Is it DS? Is there also is it just Down syndrome, or is there ASD combined on top of it? So let's move on to the next slide. Teresa's going to take the slide talking about what are some of the most common behavioral challenges with children that have the combined diagnosis.
Thank you. So these are just some of the ones that personally I've experienced with my son, Nick. He's 27 years old. And if any of these resonate with you to the point where you're like, I feel like this is really, again, I'm bringing this back up, but impacting their daily living skills, their learning, they're trying to be on a classroom Zoom call and there's some, flapping or whatever, there's some type of behavior that's kind of overtaking. If that's resonating with you, please put that in the Q&A so we can kind of really gear this for you guys, because they can be quite significant. So sensory seeking, certainly just looking for extra things, like for Nick, for instance, sometimes he'll just go and just run faucets, and again, you kind of have to look at the function of these behaviors. Sometimes it's trying to get my attention. Sometimes it's just, this is cool, this is fun, it's something I have control over. He's a big button pusher too. He likes to push the microwave fan button. And you have no idea how many stop buttons I have on different objects, like just a reminder, you're not really supposed to hit that button, or the phone intercom button. So those are just some examples of some sensory seeking that I've personally experienced with my son. Biting, teeth grinding. Sometimes if he's a little bit feeling some anxiety, I will see that, and you all may as well. I know Kathleen's son likes to do a lot of crashing into things and getting some input that way, bumping, clinging, hitting, slapping, pinching, all these. For Nick, when he gets frustrated, or if somebody tries to correct him, I guess that's what I want to say. When they try to correct him, I don't know why that's going off. Sorry. I'm in my husband's office. I'm like, what does that sound? So anyway, if somebody tries to correct something that he's done, he'll get mad. He'll just start pinching himself, and that's part of anxiety as well. Yeah. Oh, did you want to add?
No, I'm listening to you. I think it's important to think about, as you go through the list, as you said, these sensory behaviors, they serve a purpose. And part of part of our challenge in addressing them is to understand their function, right? So like you shared that it might be they're trying to get your attention. It might be the example of pinching his face. He's trying to regulate his emotions. That's about regulation. Sam needing to crash a lot. That's about trying to hit a threshold of sensory input to feel where his body is. So when you think about your child's behaviors and you really look at them, think about those three things. Are they trying to use that behavior to coordinate attention in their environment and elicit a response? Are they trying to regulate themselves and calm down? Or are they trying to satisfy a threshold that they have for sensory input? And I think those three things, I wish I had made a slide with that, but those three things will help guide you in choosing how to support them and what sensory activities you use. So I just wanted to plug that in.
Absolutely, yeah. So yeah, where was I? Playing with lava. Nick doesn't do that, but he will. He does like to, I'm just going to say it. He likes to blow snot rockets. He thinks that's like, and then look at you like, I'm like, really, Kleenex, Again, I really think that a lot of times that's attention seeking as well. And he thinks he's funny, as far as he knows. So smelling behaviors, that could be another one. Code brown, I like to call that the fecal smearing. A lot of parents don't like to talk about it. And I know I certainly write in my book, A New Course, my journey navigating Down syndrome and autism, I directly hit this taboo subject about code brown and fecal smearing. And it's a tough one. It's a tough one. We were talking a little bit about that yesterday, of how to, what purpose is that serving? And I like, Christine, I like what you had to say about that.
Mm-hmm. Yeah, let's talk about it for a minute. And then there was a question that came up in the chat, and then we'll move on to a deeper dive into sensory. And so, yeah, Teresa and I were talking about that fecal smearing. It's one of those things where, it's when it happens the first time, there's, where did this come from? How did it happen? And Teresa's circumstance, if you want to share the circumstance, and then we can talk about like how we broke it down and the meaning we made of it, at least in our minds, right? But with all of these things, we can make meaning of our child's behavior, and then, that's our hypothesis. And then we'll try a sensory strategy or an environmental adaptation to support them. And there's a lot of trial and error. You have to figure out what works for your child. So let's talk about your circumstance, Teresa.
Sure. Well, in the book, I write specifically about a time when I was trying to, or I was teaching a Catholic CCD class in my home. So I had, for his older brother and probably 4 other boys. And usually I could just put Nick up in his room and he would just watch Thomas the Tank Engine and, shut the door. That particular day, I went up to check on him, and he had done a serious, what I would call a poop casso, just everything was covered. And I still kind of scratched my head going, okay, I probably left him alone too long. And what could I have done differently? And Christine had some input into, a hypothesis, if you will. Right.
Well, we were talking about your child's individual differences, right? And so this is also something really important to bring up, is that, there's the whole analogy with children on the spectrum that they're like snowflakes. No two are the same. And it's absolutely true. No 2 children are the same. They're going to present with very specific differences. You can say overall they all have sensory challenges, but what they are exactly are different. And so with your son, Teresa, you had shared that he had significant motor planning challenges, right? And that was impacting his language. And motor planning is a very complex process that has cognitive components and motor components. And so, we were talking about his ability to generate ideas to play, like his ability to come up with, well, what do I do when I'm here in my room with the Thomas the Tank Engine? There were no ideas. And so when it's difficult for children to develop or come up with ideas of how to play, often you'll see sensory play happening, right? And so when we look at child development in general, sensory body play is what happens early on before there's cognitive development, symbolic language, and an ability to string ideas together. And so for a child that has trouble having ideas, we have to give them to them, right? We could do, we could do like a picture, like PEX, or a picture of, Duplo blocks built with the bin of Duplo blocks, and have choices for him. So, but using visual cues to give him the idea externally, so he doesn't have to generate the idea internally. And so, he was just engaging in sensory play. It's warm, it's squishy, it makes this great color on the wall. So in that circumstance, I think you're right. I think he needed some support in helping to structure his time. And knowing his individual differences of having challenges with ideation needed support there. So, all right, so to the same point, that's where masturbation can come in. Verbal stimming, we'll talk about this related to auditory sensitivity, because I believe kids will often create a sound envelope for themselves with repeated sound when they have sound sensitivity. So if they're creating and they're in control of their own sound bubble, they can prevent unexpected noise from coming in. And that's one reason, that's one hypothesis. I've also worked with kids where just those like deep guttural sounds just have like a deep body sensation, right? It creates vibration in your throat and in your chest. Those are and similar to what crashing would be, but using sound to generate that feeling. So there could be a sensory seeking component to it, but there also could be a sensory defensive component to it. And whichever one it is, we have to kind of sort it out, because you don't want to just throw any sensory strategy at a kid. And that's one thing that I'd like to get across, is that when we use sensory diets, it isn't a one size fits all. We really want to understand your child's profile so that we're picking the right activity for them. So in that example of verbal stimming for defensiveness versus sensory seeking, what we would do to support them would be different. Even treatment would be different. I skipped over pica. Pica is an interesting one. I mean, I think there is some bit of sensory seeking there and kids wanting to chew. And this came up in the chat too, is what do we do about kids that really have that desire to have things in their mouth? They're chewing, they're grinding, even biting, right? And so here's another one. Biting started recently while the therapist, when he was frustrated. And smelling behaviors. So, to get back to biting, part of it is self-soothing. If you see kids and they're doing that repetitive grinding, the grr, grr, it is almost like a rocking, right? That grinding. So that could be self-soothing, but also the jaw. You can get a lot of proprioceptive input through your jaw, through chewing and grinding. And some kids really want that proprioception. So Sam does a lot of crashing, that's seeking proprioception. So again, Sam is seeking to meet a threshold, but the child who's grinding to self-soothe is doing that for regulation, right? So threshold or regulation. And so when you have a child who's trying to get regulated, there's lots of things that we can do to support their ability to be regulated, including just keeping them engaged with you in back and forth communication. But that's something that we'll want to sort of flush out, and with real life examples, I think is helpful. And so the one that came up in the chat, let's see. So biting when frustrated, you know, that's just one of those things where the language isn't there, but they're doing what they can to communicate. And so it's important to give sort of a replacement behavior that is as immediate. So even giving him a way to say no, or to hold up a stop sign, or to raise his hand to teach him that there's some other way for him to communicate, than biting. And that's very common with children that have language delay. When they're frustrated, that they will bite, and they're really just trying to communicate. And then smelling, you know, kids, that is just that seeking. It's the smelling behaviors, you know, sniffing everything, often is a result of poor tactile discrimination. So what does that mean? Discrimination is that ability to understand different qualities of sensory input. So if you had a penny and a quarter in your pocket, and you had to put your hand in your pocket, and I said, pull out the penny, you'd be using tactile discrimination to figure out which one is the penny and which one is the quarter. What we know about children with Down syndrome in general is that tactile discrimination is impaired. They need more sensory experiences to develop the sensation in their hands, and that's often a contributor to fine motor delay. And so in development, children will go through this period where they pick up a toy, they'll stick it in their mouth, they'll mouth on it, and they look at it. And so they're feeling it with their hands, they're feeling it in their mouth, and they're taking in the sensory attributes with their eyes. And so their brain codes like, oh, that bumpy looking texture feels like this. But if there's dysfunction in any of those systems, like maybe your fingers don't feel actually the bumps on that toy. And it would be similar to like, how do you feel those bumps if you had gloves on your hands? And that's how, when we're in OT school, that's how they teach us about tactile discrimination. And imagine, you know, take it one step further. If you had gloves on your hand and you had to seed a pomegranate, how hard that would be, right? So that's the connection between using sensation. It's a precursor to motor skill. But anyway, to get back to why kids would smell, well, if this isn't working, hands on the toy in the mouth, and then looking at the toy, if that's not giving you real information about that object's sensory qualities, you're going to smell it. You just are, right? And so that could be, you know, a result of just poor sensory discrimination. So let's move on to the next slide.
Yeah, you know, before we do that, I had a few more written down that I'm going to see if resonates with anyone else. Just
sure.
As far as, you know, something like social aversion, where, for instance, Nick in high school, when they would have a pep rally, if he were to go into the gym when it's already full, that would be overwhelming to him. So we made accommodations to where he would go in before, sit off to the side, and then give him that exit. If he started pinching his cheeks, it was too loud, you know, give him that I need a break icon right there so he could hand it and escape before meltdown. Another one.
That's beautiful. Yeah.
You talked about the verbal stimming, and I certainly know that with Nick, he makes, it's kind of like a sound. It's just, and it's a humming. It's just, and for the most part, what I'm actually learning after 27 years is that's I can tell he's it's kind of regulating, and when I hear him doing that, I know he's happy. So that's maybe perhaps, as you said, his protective bubble. I was just thinking of that. And then another type of aversions are, especially with our kids, are can be like teeth brushing, haircuts. Oh gosh,
yeah.
Those are all real big challenges that I've experienced as well.
Yeah, and nail trimming. Yeah, and nail trimming too, right?
Yeah. Always after the shower or the hot tub. Get those things soft. I don't know. It's that extra chromosome. Those nails are tough though. And then just getting him. I'm here in Chicago, so getting him to wear a hat and gloves in the winter. It's just he doesn't like that feeling. So
tactile. Yeah.
Yeah, and so if again, guys, if anything resonates with you, you're like going, oh yeah, I experienced that too. Put those in the Q&A so we can help you guys out.
put them there. And I do want to point out that those are the most common sensitivities, overreactivities that we see: sound and touch, tactile. So with that being said, let's move on to what is a sensory diet. And then we're going to give you a minute to go through the handout that we gave. So a sensory diet is a tailored plan of sensory and or motor input that should be delivered to your child throughout the day to help support their arousal regulation or meet their sensory needs, right? And proactively avoid sensory overload, which is what we'll see in kids that have tactile and auditory like overreactivity. And the way that you use sensory input is going to be different based on whether or not you're trying to help your child regulate or you're trying to meet their threshold. And then it's also going to be different based on your child's profile. Are they overreactive? Are they underreactive? Are they mixed reactivity? Are they seeking and craving? So there's a whole list. So what I want to do now is give everyone the opportunity to just take about, I don't know how long it will take. It's sort of long, but quickly go through this handout that I gave you about, that goes through each sensory system, and you sort of just check off which behaviors resonate with you. And basically what it's going to do is give you an overall profile about your child's underreactiveness or overreactiveness with each sensory system. So everyone knows visual, auditory, olfactory is smell, tactile is touch, but proprioception is the one that sometimes people get hung up on and they're unclear. So proprioception is the perception of where your body is. So there's receptors in your muscles and in your joints called proprioceptors that help us understand our body position. So if I were to close my eyes, it's my proprioceptors and my body map that's helping me touch my nose accurately with my eyes closed. So I have a good body map and I can feel the position of my finger and arm so that I can touch my nose. So that's proprioception. So why doesn't everyone even just go through maybe tactile and auditory and prop, and then put in the chat box what your findings are. So I'm going to turn my camera off and give you a few minutes to get this done, and then we'll go through and talk about sensory activities for that profile. Does that sound good? Okay. I'm imagining everyone giving me the thumbs up. The handout was emailed to you. Teresa, do you know who emailed the handouts? You're muted, sorry. Yeah.
You'd think after all these Zoom calls we do, we'd note that, right? It gets me every time. I know the Down Syndrome Connection of the Bay Area sent that out, probably Teresa. I'm trying to remember.
It's in an email. It was sent out. I know it was sent out this week, just a few days ago. Yeah. So search your inbox for it.
Yeah, should have been with the Zoom link, I believe.
Okay. All right. We're just going to give a minute. People just put in the chat box when you're done, overall findings like overreactive, underreactive, sensory seeker. Nancy just responded in the chat that the email is from, you could find it either through info at Down Syndrome Connection of the Bay Area or from Teresa DiVincenzi. All right, let's give just a couple more minutes. If you all wouldn't mind just throwing up in the chat box, even if you've only looked at one area, sensory area, what your findings are as far as if your child is over or underreactive. And Maggie, take a deep breath. I'm reading your chat right now about questioning everything. Your child has everything that's being discussed today, these sensory issues. So let's get through the webinar today and connect you with Teresa to help you sort out if you need to move forward and investigate a little bit more deeply. But I'm really happy that you're here to learn more about the sensory issues. And what we do know is that children on the ASD spectrum, they always have sensory processing issues. Children with Down syndrome too have sensory issues, and they can be similar, but we have to look at the overall constellation. And again, getting back to the earlier slides, the diagnosis is really difficult because there is no clear-cut criteria and there's a lot of overlap. Okay, so I'm going to read some of these things, and then we'll get into the sensory profile in each profile. So let me go through this chat. We've got things in chat and in Q&A. So we've got children who are underreactive and they love spinning. And then Marina's sharing that her 22-year-old daughter, she started pulling her hair and biting her thumbs. Both during the day and night. She's not been evaluated for OCD. Hand flapping. So it looks like a lot of sensory seeking behaviors and maybe self-soothing sensory behaviors to regulate herself, but she avoids crowds, noisy places, and bright lights. Mixed reactivity, oversensitive to sounds. Some children are next, Erin, over-responsive to vestibular and under-responsive to auditory. That's an interesting combination, actually. Usually auditory, we see overreactive. So Erin, we'll talk about that. 35-year-old daughter seems under-responsive. Okay, good. So we're getting the hang of it. Sensory seeking. Yeah, maybe. Sensory seeking, but when we're doing things because we're upset, Sue, those are regulatory strategies. So although there's sensory behavior being used during regulation, if you don't see seeking in other times during the child's day when they are regulated, then we might not characterize them as sensory seeking, but rather that sensory strategy is helping support their regulation. So, okay, so I'm going to turn, my video is back on. Let's go, Teresa, would you mind moving to the next slide? Okay, so how is your engine running? I threw this in there just, we might be able to follow up and I can email it to everyone. But this is a visual that we use to teach kids about their arousal regulation. So we can talk about regulation, we can talk about emotional regulation, right? So where we are with our emotions if we're just right, and also attention regulation. So when we're just right, we're focused, engaged, ready to work, calm. When we're too fast, our body keeps moving. We could have big emotions. Difficulty controlling ourselves, lots of talking. And then too slow is tired, hungry, bored, sleepy, slowed down. So we can use this with some kids so that they can identify where their engine is. And then based on where their engine is, help them learn how to pick sensory strategies for themselves. So that's just a tool that OTs use, some educators use as well. But let's go to the next slide and we'll talk about specific profiles. So as we saw in the chat here, if we go to, let's go to identifying challenges with sensory processing. So that's the, I think it's the slide before. Go back one more to 11.
Oh, let's see.
That's okay. So it's okay. You're okay. We can leave it there. One thing that we know is that children generally will fit, their overall profile will fit into either being overreactive, you know, or over responsive globally, or underreactive, or sensory seeking. Kids that are overreactive, over responsive, and we can even look at specific systems, are geared towards anxiety, fearfulness, and rigidity. And the reason why is that because their nervous system is interpreting sensory input as threatening, they need to be able to control their environment in predictable ways. So, and I want to spend some time at the end of this talking very specifically about the importance of processing sound accurately and its connection to fight or flight behaviors. So when we talk about kids that are overreactive to touch, overreactive to sound, overreactive to movement, what we'll see is that quickly with certain, you know, very normal doses of this input, they will hit a threshold and they can become overwhelmed. And they can go into a state of dysregulation. And when you're in a state of dysregulation, you have several options. And this doesn't just apply to over responsive. It can be under responsive. It can also be in response to just things that happen in your environment that are unexpected, that are not even related to sensory events. So let's just talk about those options when you're dysregulated. So we all know if we're driving along and a deer runs in front of the car, we're going to have that fight or flight reaction where we might find that we're you know, our heart is racing, our blood pressure goes up, you are not able to really access your language. So that's fight or flight. So that's one option of a dysregulated nervous system. And that also can look like hitting, biting, and eloping. So running out of the building, taking off. That could be taking off clothes. It could be, pushing somebody away. Another option of a child being dysregulated, or even a person, is moving into shutdown. So shutdown is like feigning death. And these patterns are wired in the most primitive parts of our brain. We all have these emergency response systems wired into our brain. Kids with sensory issues, we can trip that emergency response system more readily. So if your child is fight flight bias, whenever they have sensory events throughout the day, one thing that we know is that sensory events accumulate. So if you have a child that's very sensitive to sound and they've had to endure, being in the lunchroom at school, a noisy ride home, maybe a siren went by, being in the classroom with some friend unpredictably touching them if they're tactily sensitive, by 3 or 4 o'clock in the afternoon, their cup of sensory input has accumulated where it could just take one more sensory event and they're in that state of dysregulation. So with these kids, let's move to the next slide, which talks about signs of overload. We might see kids eloping, running away. These are the fight flight responses. Becoming super silly, like that laughing before crying, making noise to calm, repetitive stereotypical behaviors, self-injurious behaviors, and shutdown. So these are all signs that a nervous system is overloaded, and we need to use sensory strategies, a sensory diet, It's one option to help get our kids regulated. So if we go on to the next slide, we'll talk about what are the major sensory modulators of the overreactive profile. So these are the tools that OTs love. Deep touch, pressure, tactile. So this could be hugs, joint compressions, weighted blankets, using a weighted backpack, doing wall push-ups, proprioception and heavy work, wall push-ups, jumping on a trampoline, pulling, tug of war. We also use oral motor strategies. So chewing, resistive suck, using a very like heavy smoothie. And we also, as therapists, will use auditory interventions, which they're more specialized programs and harder to cover. But if we think about a child who, like Teresa, your son, who would get overwhelmed in big spaces where the voices are bouncing off the wall, and we know he has to tolerate being in an assembly, we might use sensory strategies, a sensory diet, to prep him before he has to go in to endure that environment, and then again when he comes out. And so that's where we want to use a sensory diet that's prescribed to his specific individual differences. So we might have him do some heavy work. You know, can he do wall pushes? Can he push a library cart down to the office? Can we get him chewing something, or something even more appropriate? Can he have a water bottle to suck on, to have that suck and swallow during the assembly? And then after, can we get, deep touch into him, even brushing programs? So I'm not sure if anyone here is familiar with therapeutic brushing programs, but it's something that OTs use to give deep touch pressure throughout the body really quickly. And so even just like rubbing this brush all over arms, back, and legs to give this really intense dose of deep touch pressure can help calm down that nervous system, so that that child is able to tolerate more input, and that sort of using a sensory diet will basically take that cup that's just about to overflow and reduce the volume a little bit. And so what we want to do is give kids who are overreactive these major sensory modulators throughout the day: deep touch pressure, proprioception and heavy work, or oral motor. Those are the three that you all can do. Auditory is, again, something that we do use specialized music to help kids regulate. But proprioception and heavy work is pushing against resistance. So I want to make sure everybody knows, what do these OT terms mean? Deep touch pressure is massage, using massage, using lotion, using brushes. But kids who are crashing, if you think about what kids are seeking when they're crashing, they're getting a lot of deep touch, but they're also getting a lot of input into their joints. And then oral motor, again, so many of our kids are seeking oral input. So giving them the opportunity to chew and get proprioception into their jaw throughout the day is actually going to be calming and regulating to them. And I keep hearing the same, like kids are using vocalizations and using their mouth in a repetitive way to calm. And so just knowing that about them, they might, maybe jewelry is an option for them. Maybe, giving them a heavy suck smoothie before a sensory event that is going to be overwhelming to them would be beneficial. So that's the overreactive gang. And again, you can have children who are, in the chat box, there was a child that's overreactive to movement, vestibular, but underreactive to sound. And I think I want to explore that a little bit more, because if you were with me and I was your OT, I'd want to investigate a little bit more about the underreactive to sound. Again, I think children use sound in making sound themselves to create a sound bubble, but that child also might not be orienting to sound. So let's move on to underreactive. So kids that are underreactive, that usually goes along with the low tone. They're they might seem lethargic, they're hard to engage, they might appear like they don't hear you, they're missing, like someone might walk in a room and they don't even notice that person walks in the room. These kids will also often like bump and pinch. Sometimes they also spin, and what they're trying to do is bring up their arousal so that they can focus in their environment. So if we move on to, okay, major modulators, what's the difference? So if you have a child that, let's move to the next slide, who's underreactive, one of the things that we love to do is get them moving. Think about like a dance party, right? Where you're going to have auditory input that's sort of changing. It's unexpected, it's unpredictable. You swing them and the movement is rapid and changes positions. That kind of input is really going to bring up their arousal level and their ability to attend to cues in the environment. Heavy work is also one that we do. We love heavy work for all kids. And think about all of the adults that need to get their workout in every day. Like you've got to go for a run, you need to go to the gym. And, you know, when you're managing stress, we as humans use heavy work all the time to stay organized and regulated. So heavy work cuts across both profiles. And then tactile tools. So, you know, using sensory play can help alert these kids. And this kind of sensory play is going to be things with real sensory qualities, cold, wet, squishy, all that icky stuff that might help to bring their arousal up. Oral motor, oral activities using sour, sweet, like really intense flavors to sort of wake up the mouth is also very helpful for children that are underreactive. In fact, in feeding therapy, we use a lot of intense flavors with kids that have this profile to help them feel like, oh, there's my tongue. Like we even use those little pop rocks that pop in a mouth, and you'll see a kid like, oh, like there's my mouth, there are my cheeks. So you want to give these kids novel sensory input across all sensations. So then what about, let's move on. And I'm kind of going quickly because I want to make sure we have enough time to answer questions. What about these sensory seeking kids? And that's the next slide, Teresa. So sensory seeking kids, they're kind of a puzzle because on the outside, they look like they're they look like they're underreactive and they're looking for input to bring their arousal up. But what's different about the seeking kids and the underreactive kids is that when the underreactive kids are seeking input, they get their needs met and they can pay attention. Whereas seeking kids, they just become more and more and more disorganized. So it might be that they're seeking movement and more movement and more movement, and then you have the big blow up and meltdown and tantrum. They just can't get themselves organized. They can't get grounded. And often that's because they have overreactive systems under there. They're actually defensive. They might be touch defensive. They might be movement defensive, even though they're seeking it. So this is a tricky profile. And so when in doubt, with these kids, sensory seeking kids, I'm hesitant to spin them because I don't want to prescribe spinning for any child who's sensory seeking, because it might be that vestibular input is going to lead to a tantrum. But we do know that deep touch pressure, tactile input is regulating and organizing. Proprioception, heavy work, oral motor again. So, you see these three things show up in each profile. How are they different? And so that's the thing that we want to really kind of feed out. How are they different? So between an overreactive child and an underreactive child, tactile input in the child who's sensitive and overreactive needs to be predictable. It needs to be consistent. Whereas the child who's underreactive, it needs to be unpredictable, have more enhanced qualities to it to get their arousal level up. Deep touch, pressure, and massage with an overreactive child, again, you probably would do it in a very calming, consistent way. Whereas a child that we're trying to upregulate, we might want to do deep touch pressure with a therapy ball and sort of bounce it on their body. So there's sort of this unpredictable input happening with that child. And so as an example, we love to use weighted vests as OTs. A weighted vest gives deep touch. It also gives a child the opportunity to move their body against resistance. And so if we have a child who is really low tone and underreactive, if we put a weighted vest on them, which is the sustained deep pressure, their arousal is going to go down. And I remember teaching an OT. She was a student of mine, and she wanted to put a weighted vest on this little guy who, you know, was very low tone, very low arousal. And I said, okay, well, let's see. You know, she wanted to try, and she looked at me and she said, he looks like he's tranquilized. And I'm like, yeah, it's too much input, and it brought his arousal down. And so what he needed touch, but he needed it in an unpredictable way. I'm hoping that that's making sense. Okay, good. All right, so let's go through, I want to go through a sample daily routine of a sensory diet. But I want to check the chat box quickly to see if we have any questions that have come up. Let's see. Okay. Over on auditory is coming up all the time, so I want to spend a few minutes talking about that. Bouncing and swing, but is under for seeking. Okay. Chat. Okay, good. All right, so let's move on to a sample daily routine. And again, I think it's really important to know your child and know if they are, are you using input to meet a threshold, or are you using sensory input to help them stay regulated? And because the way you use that input will be a little bit different. So Teresa, if you can go to the next slide, that'd be great. So if we think about this with regards to a child that is underreactive, so a child who's underreactive, and then we can kind of go through and talk about how we would adapt the same profile for a child that's overreactive. So in the morning before dressing, we might want to give them a good dose of lotion and massage, deep touch. This is where your body is. Sing a song, rub their arms and legs. That might help wake up their tactile senses, increase their arousal, help them feel where their body is in space, which actually could help them with the motor demands of dressing. Maybe before breakfast, your child gets to go jump on a trampoline with music playing in the background to help bring their arousal up, and then sit them down for breakfast, and they have that real strong resistive suck through a straw. So what you've given your child in just that daily routine, and looking at trying to amplify the sensory components of activities that happen in your daily life, is the best way for you to be able to be successful with sensory diets. We don't want to give you added work. We just want to tell you how to add sensory components to the things that you're already doing, so that your child's getting the sensory input that they need. So that's morning, you're giving deep touch, you're giving proprioception, you're giving them that oral motor challenge, which is helping feed all of those systems: proprioception, touch, even movement. In the middle of the morning, maybe your child will need a break where they're crawling through a lycra tunnel, which is a stretchy tunnel, or you have them do animal walks, blowing puff balls, blowing bubbles if they can, playing with Play-Doh and messy play, tactile. And so depending on your child's profile here, you would change the quality of this activity. Animal walks are wonderful for kids who are over or underreactive. It does require muscle tone and motor planning to be successful with those things. But what they accomplish is a lot of weight bearing through the big joints. So if you imagine bear walking down a hallway, a child's going to get a lot of input into their elbows and their shoulders, their hips and their knees, and giving them that input might help them not need to crash in that next hour or later. Blowing bubbles, if you think about blowing, a lot of our kids are making vocalization sounds. You could also do doing kazoos to music is a nice way to give them that, give them the oral motor work that they're seeking to stay regulated. And then playing with messy play, you know, some kids playing with Play-Doh, playing with foam, playing with gack, those things are really regulating to kids. In the middle of the day, perhaps having jewelry around their neck would be helpful for them to get that oral motor input that they need to focus. Jumping and crashing. I think having dance parties and crash parties are really great with kids. So if your child is starting to bang or pinch or hit or rock, give them opportunities to roughhouse, set up a goal-directed sort of activity where maybe there's puzzle pieces on, you know, you take your couch cushions and you throw them on the floor and they jump off and grab a puzzle piece and then climb back up and put the puzzle piece in the puzzle board, something like that. And you, of course, adjust that to be developmentally appropriate for them. But giving that hit of proprioceptive input in the middle of the day, again, you've done it in the morning with trampoline, you've done it mid-morning with animal walks, now you're doing it again with rough housing, jumping and crashing. You might want to have opportunities for swinging. So let's talk about swinging here. OTs love to swing. And a lot of, you know, people will come to therapy and say, okay, you know, I think we need to be swinging our kid, but we need to really be mindful about the kind of swinging that we're doing. So a child who truly is underreactive and low arousal will benefit from rotary swinging around and around, quickly changing positions. Whereas a child who is overreactive to movement, they're sensitive to movement. If you give them that kind of input, spinning, unpredictable movement, you're going to see them become dysregulated. So that child needs linear swinging. So like on a glider, back and forth, rhythmic back and forth is very soothing, whereas spinning around and around is very activating. So you have to choose which type of vestibular input you want to match your child's profile. I hope that I'm making sense. And then at bedtime, sensory diet activities, obviously we want to be calming our kids. So we're going to use calming strategies like a salt bath. I love salt baths. Epsom salts are magnesium, and magnesium is a calming element. Most Americans are deficient in magnesium, and so it's something that is very useful for all of us to be taking, both orally. There's something called CALM, C-A-L-M, that you can purchase at Whole Foods in their supplement aisle that some families will also use with their kids to make them a little calm drink before bed. Take a salt bath, give them deep touch, foot massage, body massage, a warm weighted blanket, or wrapping them, swaddling them in towels that just came out of the dryer. Soft, you know, rhythmic music can be calming for bedtime. So that's just one example of how to exaggerate the sensory components of regular things that happen in your day so that you're supporting your child's regulation, but also meeting the thresholds that they have. So let's pause there, and I'd love to answer questions, take some scenarios, and then I'll talk a little bit more specifically about the connection between the middle ear, your ability to filter sound, and regulation, because we've learned a lot about that in the past 5 years, and I want to pass on that information. So let's do questions first.
Yeah, you know, you mentioned the salt bath. Nick doesn't take baths; he showers. So I use the Dr. Teal's lavender Epsom. It's a body wash, and I've got lavender spray. So he's getting
That's
the whole
great
spa experience. Question. I have a question. Where's my hand?
Yeah.
Yeah,
I got it.
Weighted blanket. Can you touch on the weight, the recommended weight of the blanket compared to the child's weight, and how long they should wear that?
That's a great question. So the rule of thumb is 10% of the body weight. There is a company called, I think they're called Dreamtime Baby. They're actually located in San Ramon. They make weighted sleep sacks, which are amazing for kids that are like 3, and even under. And so, the old rule of thumb was 10% of your body weight. Don't use the weighted blanket or weighted vest for more than 20 minutes at a time. And I think that rule is appropriate if you're using that tool to help with the child's arousal regulation during the day. So if you have a child that's a real seeker, they're always on the go, they don't stop moving, putting a weighted vest on them will be useful for about 20 minutes, and then their nervous system sort of habituates to it. There are kids that really need the weight in a blanket to sleep all night long. And I don't think there's real contraindications to that once the child is big enough, obviously, to be able to move safely. You don't want to put a weighted blanket on an infant or a toddler. But that's why I bring up that idea of this company that's making the sacks, because they literally zip them in, their arms are free, and the weight is around their body. And, kids who are fussy and colicky, they really need that input and benefit from sleeping with that weight at night. So I hope that answers the question. Yeah, okay. All right, I'm going to the Q&A. I started to dislike Play-Doh because he wants to eat it all the time, all kinds. It becomes a fight. Any suggestions? I think that, that I would do food play then instead of Play-Doh, to give him, give your child options for things that he can eat, because, it's setting up a negative circumstance where you have to have this fight all the time. So I would, when you're giving him tactile play, make it edible. We do that all the time in therapy. Let's see, by implementing a sensory diet, what are we hoping to avoid? My son doesn't have that many major meltdowns, but does a lot of teeth grinding and vocalization. So implementing the diet, would I be hoping for him to not do those things? Right, so you know what? I wonder if your child is underreactive, right? So no major meltdowns, he might be lower arousal, he's grinding his teeth and vocalizing to sort of self-soothe, maybe bring up his arousal level. So if you were to use even music like salsa music in the morning, using intense flavors like lemon icy for him to crunch on, playing kazoo to music at lunchtime, you might see that by giving him these sensory opportunities in play, you might see that grinding and those vocalizations reduce throughout the day. So yes, that's exactly what we're looking for in your circumstances, to give him more intensity of sensory input in the areas where he's seeking, so that we can help hit the threshold that he's looking for. Hopefully that makes sense. Okay, my son vomits at feeding, and also when his senses are overwhelmed. What can we do to help him? He's very, very over on oral. Yes. Okay, so you've got a profoundly overreactive system. And so his brain has coded food as danger, so much so that he's, vomiting to expel it from his body, which is really a defensive reaction. And that's pretty significant. I'm wondering if that happens with certain textures. We see that also. Kids might see a texture. Like I once had a child that saw like one of those little spiky balls and gagged and vomited just by looking at that, right? And so what we know is that nervous system has not coded the sensory attributes of that thing, the spiky ball or the food, as being safe. So they're always going to be moving into, defensive positions. The circuitry in their brain, again, is going to move into defensiveness, which in this case, he's throwing up and he gets overwhelmed and probably shuts down, right? I bet this kiddo goes into shutdown and not fight flight. Typically, that's what happens with people that are really overreactive, is that they have to just shut down. So, Serene, I would tell you that likely, given the intensity of this, that he needs therapy, because it's no quick answer for a child who's vomiting at the sight of certain textures. You need to go through sort of this graded way of introducing foods that match his sensory abilities as well as his motor abilities, to start to develop a sense of safety around food. And this is where I'm going to kind of plug in my personal opinion around feeding programs. There are several different ways to approach feeding restrictions. I personally like this SOS method, which is the sensory oral sequential method of feeding. And so what the SOS method does is we look at the sensory abilities of the child, what sensory attributes can they tolerate. We look at their motor skills. We look at their developmental stage of their skill in their mouth. And then we look at the food that they're eating. And we move them along a developmental continuum to expand what they can tolerate, to develop more skill in their mouth, and then move the demands of the food to match that along. So it's very much developmental, and it also respects the child's individual differences. That's considered a developmental approach. The contrast to that would be a behavioral approach, where we're going to disregard that the child can't tolerate mixed textures, but we're going to reward that child with TV if they put mixed textures in their mouth. So I'm not a fan of that approach, because I don't believe that it generalizes. If your child doesn't have the skill, sensory or motor, to manage that mixed texture, as soon as you take away the television, they're going to be refusing that food again. So I have a very strong preference in a developmental approach for feeding therapy. And in this circumstance with your child, Serene, I would recommend a developmental feeding program. So let's take a minute, if it's okay. Let me check the other spot for questions. I think that's it. More chat. If I missed anything, Teresa, let me know.
Okay, yeah, I'm keeping an eye out here.
Okay.
You mentioned the food refusals. I will give you guys a little bit of hope, because Nick was, stuck on just so many things, and he still to this day does not like to eat fruit. But I supplement much more on the vegetable side. And but once he got into high school and they had a weekly cooking program, his palate really opened up. I think it was a lot to do with his peers and him being able to be in control of cooking it. And so that was huge.
I love that. That's a wonderful story. One of the things that COVID has really gotten in the way of for us at Child's Play is being able to offer group feeding, feeding with peers, because we do find as therapists that if kids have that ability to have food play, and this is what the SOS method does, is, before we expect a child to eat anything, they touch it, they play with it, they do art projects with it, right? And so, and that's the equivalent of like a preschooler, like, let's play with it, let's build a train. But a high school, it's, well, let's prepare this food together. And we're doing it with peers. So what you're doing is you're giving the brain cues of safety. And so this is something that's going to lead us right into this, a little bit of discussion on sound sensitivity and regulation. And so one of the things that we all do, all of our brains do, is this process called neuroception, where our brains, every moment, we're taking in sensory attributes of the environment and we're processing our safety. Are we safe? Are we safe? If we're not safe, we're going to trigger that emergency response system, which we know we have fight or flight, withdraw, avoidance, all the way down to shutdown. And really profound examples of shutdown is when people actually leave their body and dissociate. That's part of the regulatory emergency response system. So that the child who sees food and it elicits a gag response, there's no cue of safety there. And so therapy needs to go through a developmental continuum of help, matching the child's skill and tolerance of sensory input so that we can slowly build their sense of safety so their brain doesn't believe they're in danger anymore. So what's really fascinating about the way that our emergency response system is wired is that we can use sound to unweight a system that is prone to overwhelm and fight or flight. And I'm going to explain the science behind it. So we have our 10th cranial nerve is our vagus nerve, and our vagus nerve innervates our heart. So it's responsible for the way our heart's beating and how fast we're breathing. It innervates our organs and digestion. And when you have the emergency response system turn on, it unweights that vagus, and you have norepinephrine, epinephrine, and you've got all of these defensive reactions happening. And so kids that are overreactive in the world and they come out sensitive to sound and sensitive to light, their nervous system is skewed to emergency, and they live often in chronic dysregulation, where they might not be in fight or flight, but it's right there under the surface. And if we look back to, primitive brains like amphibian brains, this is the piece that I love, and I'm hoping that I can explain it correctly. The ear bones, the middle ear has, the ear bones in humans that are free moving. And so we are able to, our brains are wired to process the higher frequency voice of mom with sort of prosody and rhythm. And that part of our brain in middle ear and the way the ear is wired is connected to our social engagement system, which includes this part of our face. So when a child is regulated, you'll see softness through their eyes. Their pupils are not dilated. They're able to talk to you calmly. They can take in prosody of voice. But when you have someone who's dysregulated, this part of their face is frozen, their pupils are dilated, and they actually are not really responding to sound. Now, what we know about the middle ear is that the middle ear should filter out low frequency sound. And we have a feedback loop in the brain where low frequency sound trips emergency. Low frequency sound is the predator coming. It's the growling lion. It is the blender that sets your child off. It is the toilet. Those low frequency sounds, our middle ear should be able to filter out. And the way that our middle ear does that is that it's a parent once explained it to me after we talked about it. He said, well, it's kind of like when you squint your eyes to keep the bright light out. Your middle ear should squint and your eardrum tenses and it keeps that low frequency sound out. When there's low tone, when there's recurrent ear infections, certain diagnoses like Down syndrome and autism, that middle ear is not working to keep low frequency sound out. And so kids are doing it themselves by covering their ears. They're doing it themselves by making a sound bubble to keep that low frequency sound out, because when that low frequency sound comes in, guess what happens? Their emergency response system is tripped. And then you're in fight, flight, or you're in shutdown. So this whole explanation is coming from the work of Dr. Stephen Porges, who developed the Polyvagal Theory. And basically what he says is the vagus nerve, when we move from amphibians to primates, the ear bones became free floating. We have a branch of the vagus nerve that innervates the middle ear. We're able to process sound, high frequency sound, and it's connected to social engagement. And so when you have a child who is sound sensitive and they're always overwhelmed by sound because that middle ear is not working, the social engagement system is shut down because they're in emergency. So those things go together. So Porges developed an intervention that it launched 2.5 years ago, and I was number 3 on the list to get it because I had read so much about it and couldn't wait to try it. It's called the Safe and Sound Protocol. And he uses music as a portal into the vagus nerve to help improve the ability of the eardrum to squint, to filter, but also to calm down that nervous system by activating the vagus nerve. And all I can say is it's amazing, amazing. Kids that are on the spectrum who have sound sensitivity, you know, we've had parents literally call us from being outside, one mom crying, saying, I've never seen my child, you know, behave the way that she is. I can tell she feels safe. She's approaching other children. Just major shifts in a child's ability to be calm, be regulated, and engage socially, in addition to reducing the sound sensitivity. So the way the Safe and Sound Protocol is administered is you have to find a provider. We are providers, but I'm not promoting us. I'm just really excited about this intervention because it is, I believe it's pivotal. Porges is doing a lot of research on it and publishing papers in efficacy. And one of his very first papers was to show efficacy specifically in children on the spectrum in reducing sound sensitivity. But we're also using these protocols in people with PTSD, people with trauma, because the similar experience of that emergency system always being on guard is there. And some people even make the argument that kids with really profound hypersensitivity have trauma. You know, they have a nervous system that's experienced trauma just because of their sensory sensitivities. So the way that we administer it is we have to do a questionnaire to understand the level of the person's sensitivity, and then we prescribe a program where you basically are listening 30 minutes. So kids need to tolerate headphones. If they don't tolerate headphones, it is possible to do it, start in open air. And then the program could be anywhere from 1 to 3 weeks long, 30 minutes to an hour of music a day. And that's it. And then we'll do it again in 6 months. And sometimes, you know, we've had families who've wanted to do it a second and a third time, and we continue to see results. But I would encourage you to go and read about the Safe and Sound Protocol, Polyvagal Theory. The company that is, it's called Integrated Listening Systems. That's the company that is renting out Safe and Sound Protocol, but you need to find a provider. So, and the wonderful thing is that you don't need any special equipment. It used to be when Porges first came out with this, I had a kit. So I'd have to physically give you the kit. But now we put the music in a portal. We put the whole music plan there. You have to have headphones that cover the ears in order to listen. And you can consult with providers remotely. So no matter where you are in the country, you could have access to Safe and Sound. So anyway, hopefully that makes sense. I think we're at 11:30. If there are any questions, if you guys don't mind throwing them up in the chat. Otherwise, I think I've gone over everything. Now that you bring up the blender, my babe had a G-tube and eats a blended diet. I have a whisper box, but it still does not work. Any suggestions on getting a child to accept the sound of the sweeper? Yeah, they get upset from, yeah, is there an approach to help with this? Yeah, so Maggie, the Safe and Sound Protocol, it's really just about he has this coupling of that low frequency sound is tripping that emergency response system, and you're seeing his nervous system go into emergency, which is vomiting, crying, probably shutting down. And so that's very primitive neural circuitry that we can address with neural interventions.
Yeah. I just got to thinking about our conversation yesterday, and how Nick, we just got this air fryer, which by the way, guys, is awesome. Except not to
I love
Nick.
the air fryer too.
Come on, fried chicken. So literally and so Nick, well, he likes to pump up the volume on his music or whatever he's watching, but then you turn that air fryer on and he just starts taking whatever's in this path and throwing it. And now it makes sense to me. It's that fight or flight, need to escape that sound. And I got to thinking while you were talking about this, that he did have quite a few ear infections when he was growing up. So that makes sense. His middle ear is not able to squint to block that out. So that's a aha moment, as Oprah would say.
It's incredible. It really is. It really is how, we can have something anatomical, something, that is mechanical, that is having a direct contribution to our ability to stay regulated and to feel safe in the world. And, cues of safety are really important to all of us. And sound is not something you can see, right? Like we can't see sound. We don't know when it's coming. And so when people are profoundly sound sensitive, you'll see a level of anxiety and need to control because of that lack of feeling safe. And so, giving kids, always connecting the sound with the visual of where that sound is coming from is really important. Anytime a child hears a sound and they're concerned, oh, that's the school bus, let's go see it. You always want to give them that opportunity to make that connection in their brain between that sound and what that thing looks like. But kids that have middle ear dysfunction or, profound sound sensitivity that cuts across their life and is impacting their function, I would say, let's try an intervention. There's no contraindications with this. We're listening to music. So the risks, are really small compared to the possible benefits that you'll experience using the Safe and Sound protocol. There's also other listening programs and devices out there. Integrated Listening Systems makes something called the Dream Pad, which is something that I also recommend to families often for kids that have trouble soothing to go to sleep. The Dream Pad is very helpful. Kids that are not sleeping through the night and missing that last cycle of sleep, which is around, the 5 o'clock wakers, they're missing that very last bit of sleep. The Dream Pad seems to help. Kids that are always on the go, sensory seeking, the Dream Pad also reduces that need to seek in the day after when they're listening. And the Dream Pad is something that you don't need an OT for. You can go try it. You can go to Integrated Listening Systems, buy a Dream Pad, give it a try. I think they have a 30-day money back guarantee, but my experience is that once a family has one, they have, as many heads as they're in the house because they're so soothing. It's a wonderful product. So the Dream Pad is another product. Safe and Sound is something we use, episodically. And then Integrated Listening Systems also has a therapeutic listening program called the Total Focus System, which we use to work on skill. We use those programs to work on sensory motor development, attention and focus, auditory processing, speech and language. And it makes sense, if we're going to work on fine motor skill, right? Like how do we hold a pencil? How do we cut with scissors? Or motor skill? How do we do jumping jacks? How do we get the brain wired up where different parts of the brain are communicating with each other fluidly? And what we know about autism is that the interconnectivity in the brains is not as profound in a child with autism. That's where the challenge is that different parts of the brain, they're not talking to the other parts. Kids with autism are highly visual. But the proprioceptive and, the sound part of their brain is not integrating with the visual part of their brain, is not integrating with the motor cortices. And so that crosstalk is missing. And what the therapeutic music programs can do is to really, it helps to rewire the brain so those networks develop. And I've done pre and post tests with kids who are getting OT for coordination disorder, motor planning issues. And when they do OT with a music program, they achieve gains that I can't ever achieve just with therapy alone. And I think of it as just another brain-based intervention. If you think about sound coming in right and left side, it's stimulating the brain to talk, the hemispheres to integrate across, but also the headphones have vibration in them, and that vibration stimulates the movement system. So that's called bone conduction. And so we're really giving a lot of sensory input when we're using therapeutic music programs. So I love them. And that's why on the slide, auditory programs is included, but there's just so much to talk about in the way that they can be used. But what you can do, as a parent, is you can look into the dream pad. If you have a child that has trouble sleeping or is always on the go, highly anxious, the dream pad can be very helpful as part of a sensory diet. And you can also just check out Safe and Sound if you have a child with auditory sensitivity. And anyone's welcome to reach out to me anytime with questions. That's why I included my email there. So, all right.
We've got a question from Aaron, and maybe you answered this. Does the Safe and Sound protocol apply to kids who are under responsive with auditory?
Yeah, Aaron, so I want to know more about under responsive. I would say yes, but if you don't mind chatting in a little bit more about what you're seeing with your under responsive child. And so this is where I would do an intake questionnaire to learn more about what specifically is going on. If your child is not having challenges with regulation or social communication, we might move just to a therapeutic listening program. But I think that Safe and Sound protocol is so powerful that my answer to you would be, if your child is low tone and underreactive overall and underreactive to auditory input, using the Safe and Sound protocol might help to get that inner ear working in a more functional way that helps them be more reactive to sound. Okay, yeah, there's a bunch of questions here.
Yeah,
can a
Kathy's
child
asking, oh, go ahead.
Yeah, can a child be underreactive and or overreactive at different times during the day? Yes, they can be. But usually they have a predominant profile for that system. So a child who's tactily sensitive and overreactive is always going to be overreactive, but they might seek tactile input, if that makes sense. Next question, is it possible to try the sound therapy with a 35-year-old girl who has difficulty regulating herself? Yes, there's no age restriction, and we're using them in with adults. Years ago, we looked into auditory training. How is this protocol different? Well, Sue, the Alfred Tomatis started therapeutic listening programs, decades ago, 20 years ago. And all of these programs have sort of spun off of his very early work. But the Safe and Sound protocol is something very different. And that work, that protocol was developed out of Stephen Porges' work on polyvagal theory. And so it is actually different than the auditory training that was used years ago. That auditory training was used more to help improve the mapping. It's called the tonotopic map in the auditory cortex, with the very specific intent of helping support auditory discrimination, auditory processing, speech and language. Whereas the Safe and Sound protocol's goal is to directly impact the vagus nerve for improved regulation. So they're different. Okay, there was one more question. Let's see. It was in Q&A. I think it was in the chat. Did I miss anything, Teresa?
Just some feedback from Mina. Wow, thank you so much for all the information you shared today. She is an SLP at an autism clinic, and this information makes sense and describes her clinical experience so perfectly. She says, I love that the information was backed with scientific explanation. Please make this recording accessible. And yes, all our webinars, this is the fourth one, are on the DSCBA website. And I'll share that information with you when we close.
That's great. And Mina, it's wonderful to have a colleague here. I have a webinar on regulation. If you're interested in it, I'll send it to you. Just send me an email. All right, I think we can wrap it up. What do you think, Teresa?
I believe so.
Oh, sorry, Serene, my question hasn't been addressed yet. Do you see it? Let me go up. Oh, here we go. We are looking for developmental feeding therapy for a son who vomits. He's due for heart surgery within 1 year's time. Should we get the feeding oral issues better before we go for surgery? I heard that intubation can cause a lot of oral aversion. We're going to ask for IV meds or suppositories for him. Wow, you've got a lot on your plate, Serene. I'm not sure that I could answer that question for you either way. If you're considering surgery, there's clear medical indications that need to take priority and need to be considered. I think your child has certainly experienced trauma around feeding and the mouth. And there's never a wrong time to start addressing that sort of thing. And so I'm happy to talk to you offline too and give you some recommendations on, different types of therapists that you could look to. OTs are not all the same. They all have different training. MFTs also might be an option. Somatic therapists working specifically with children on trauma, that's another option. So I'm happy to talk through those things with you. But again, as far as addressing the oral aversion, you definitely will need to do it, and likely will need to do it after surgery, and it would not hurt to start before surgery. I hope that answers that question.
Yeah, Christine, I really appreciate all this information. I mean, 27 years in this dual diagnosis field, and I continue to learn more things. Specifically, just really looking at the function of what that challenging behavior that's taking over sensory-wise, whether it's trying to meet that threshold or just trying to stay regulated. I mean, really looking into that, and then how can we support our kids? How can we? I mean, ultimately, it's about supporting our loved ones, with the dual diagnosis. Just giving them those tools to help regulate and, like I said, to meet those thresholds. And then I think when our kids feel safe, they can express themselves more freely. They're going to learn better. They're going to be more engaged in daily life for sure. So, and ultimately, I think that's going to help maximize their potential. So if you guys in the chat, we'd love to see what aha moment you had. What's one takeaway that you want to try some of these toolkits, this awesome toolkit that Christina provided us. We'd love to see that in the chat for the next minute or so. And then while you're typing that in, I just want to say thank you on behalf of the Down Syndrome Connection of the Bay Area for joining us for this webinar. And we have all the recordings this is the fourth. So the first webinar was kind of our Down Syndrome Autism 101, if you will, that we did with Dr. Spinazzi. The second one was our structured teaching, which gives you some good tools for activities you can do at home too. And I find with my son, Nick, when we do these activities, sometimes I have to alert him more. Sometimes he'll just fly through them. So I'm constantly doing that sensory diet to help support him on those structured teaching activities. Following the activities, he's always much calmer. So that's, you can kind of see how these are all tying together. The sensory piece, but also the third webinar we did was on AAC devices. And that was augmentative and alternative communication. So when we put together those supports, we put together the communication piece, the sensory piece, and then we can help them with the behavior piece. And that leads me to our next webinar in May, and that is all about ABA and behavior. So we are so excited. This is going to kind of be the grand finale. And I'm starting to think that maybe we should have a wrap party after all these webinars, and where we can get you guys on the screen and see if there's any more questions that you guys have. I mentioned DSCBA. It's a www.dscba.org. We offer consultations for our Down Syndrome Connection, the Bay Area, for dual diagnosis, and I do those. We also have on the website, you'll go to Education tab, scroll down, you'll see dual diagnosis, lots of resources, and also you'll get the link to my blog, which I have been writing since 2012, and also the link to my book. So there it is, a new course. But you can also visit me and Nick, a lot of Nick, on social media. We're at Down Syndrome with a Slice of Autism on Facebook and Instagram. And you can actually see a lot of the videos. You're going to see him sometimes rocking to some music. You can see him doing these structured teachings. So it's kind of putting that all together, so you can see what, how we kind of navigate a dual diagnosis. So thank you. And let's see, did we get anything else on the chat? Oh, let's see, we got 4 more. Like Erin says, I had an aha moment in regards to the reasons for vocalizations being either defensive or regulatory. Aha, I love that.
That's good. Me too. That's excellent. Great. Well, thanks for having me today. And please feel free to reach out to me if you have any further questions. I might not answer immediately, but I promise I'll answer.
And I will also drop my email if you if you feel like there was not a question that we answered. It's a TJ, last name is Unnerstall there, UNNER STALL @comcast.net.
Great.
All right.
All right. Thanks. Have a great rest of your Saturday.
Bye. Thank you all.
Bye.